All right, if you're gearing up for the MRE, you know cardiology is where you can really rack up the points or lose them. But listen, forget memorizing pages of theory. This exam boils down to one simple question. What's the next best step? What do you do first? And just as important, what do you absolutely not do? That's exactly what we're breaking down today for ACS and acute dyspnea. Let's jump right in.
So picture this. You're in the ER. The doors burst open. A patient is wheeled in, clutching their chest, sweating. The whole room looks at you. This isn't just some abstract test question. This is the exact moment the EMR is preparing you for. The clock is ticking. What's your first move?
So that first move, it's all about triage. It has to be a rapid-fire process to figure out who's the sickest and to start those life-saving interventions right there on the spot. Here are the absolute must-dos in those critical first few seconds. Okay, here it is. This is your 30-second chest pain algorithm. Before you do anything else, you check for stability. Airway, breathing, circulation. Get a full set of vitals. Then, two things need to happen almost at the same time. Get an ECG within minutes. Seriously, this is non-negotiable. And give aspirin, as long as there are no contraindications like a major allergy or an active bleed. As that's happening, someone is getting IV access and hooking them up to the monitor. These 4 steps are your bedrock. Okay, the patient is stable for now. Your next job is to figure out what's going on. The EMREE absolutely loves to test your ability to spot and act on acute coronary syndrome or ACS. So let's break down what that really means in a practical sense. The easiest way to think about ACS is as a spectrum. It's really just an umbrella term for any situation where the heart muscle suddenly isn't getting enough blood. Under this umbrella, you've got the big one, the STEMI, along with its cousins, NSTEMI and unstable angina. Figuring out which of these you're dealing with is going to dictate every single thing you do next. And here's the key difference. For a STEMI, the ECG is the star of the show. You're looking for that classic ST elevation or maybe a new left bundle branch block. This tells you there's a complete blockage and that patient needs to get to the cath lab for reperfusion immediately. Now, on the other side, with an NSTEMI or unstable angina, the ECG is way more subtle. You might see some ST depression or T-wave inversions, or it might even be normal. So here, the troponin becomes the tiebreaker. If it's elevated, you've got an NSTEMI. There's been damage to the heart muscle. The second you see those ST elevations and call it a STEMI, a new clock starts. Priority number 1 is reperfusion, getting that blocked artery open. That means activating the cath lab. At the same time, you're loading them up with dual antiplatelet therapy. That's aspirin plus a P2Y12 inhibitor, and starting anticoagulation like heparin. You'll also manage their pain, maybe with nitroglycerin or morphine, but you have to be careful. It is a mad dash against time, because time is muscle. And now for the really high-yield part. Knowing what to do is great, it gets you points, but knowing what not to do, that saves you from losing points. These are the classic traps that the EMRE loves to set. Let's kick it off with trap number 1. Nitroglycerin is a fantastic drug for chest pain most of the time, but it's a vasodilator. If you even suspect a right ventricular infarct, which you often see with inferior STEMIs, or if the patient is already hypotensive, or if they've recently taken something like sildenafil, giving them nitrates can make their blood pressure totally bottom out. It can be catastrophic. The exam will definitely test you on this. Trap number 2 is all about speed. You've heard the phrase, time is muscle, right? It is absolutely true. The ECG is the one thing that tells you whether you need to activate the cath lab right this second. Waiting around for a troponin result or any other lab before getting that first ECG is a critical mistake and a guaranteed wrong answer on the exam. ECG first, always. And trap number 3 revolves around that sneaky little biomarker, the troponin. A single negative result in the first few hours means almost nothing. Seriously. It takes time for that enzyme to leak out of damaged heart cells and show up in the blood. So, if your gut tells you this is ACS, but the first troponin is negative, what's your next best step? You got it. Repeat it. All right, let's pivot. We've covered chest pain. Now, let's move on to our second huge topic, acute shortness of breath or dyspnea. The big challenge here is figuring out the cause, and fast. So let's build a quick mental filter to sort through the big culprits. Think of this as your rapid-fire cheat sheet. For heart failure, the clue is fluid overload. Look for things like orthopnea, swollen legs, and then see pulmonary edema on the chest x-ray. For a pulmonary embolism, or PE, the classic story is sudden onset chest pain that's worse with breathing, plus a fast heart rate. For COPD or asthma, just listen. The defining clue is often that wheeze. And for pneumonia, you're looking for signs of infection, fever, a productive cough, and you'll see a consolidation on the X-ray. This is how you quickly narrow it down. Okay, we have covered the algorithms, we've marked the traps, now it's time to actually put this stuff into practice. Let's run through a couple of quick EMREE style cases. I'll give you the setup, you think about the diagnosis, and that all-important next best step.
All right, case number 1. You've got a 55-year-old man, classic story, crushing chest pain, super sweaty. You get the ECG and boom, ST elevation in the inferior leads, I3 and AVF. So, what's the diagnosis? And more importantly, what's your immediate action and what major trap do you need to look out for?
If you said inferior STEMI, you are spot on. Your next step is to hit that button to activate the reperfusion pathway and start all your standard ACS meds. But wait, here's the critical thinking part. With an inferior MI, you have to be worried about right ventricular involvement. And that means before you even think about giving nitroglycerin, you need to assess for it. This ties right back to exam trap number 1. See how it works? Ready for another one? Case 2. A 32-year-old woman, she's 2 weeks postpartum. She comes in with a sudden onset of shortness of breath, her heart is racing, and she has chest pain that gets way worse when she takes a deep breath. What diagnosis should be screaming at you from the top of your list? I mean, this is textbook, right? The risk factors, the symptoms, it all points directly to a pulmonary embolism. Now, your next step is totally dependent on how stable she is. If she's unstable, hypotensive, altered, you're thinking about a bedside ultrasound and maybe even thrombolysis right then and there. If she's stable, you have a little more time to get the gold standard test to confirm it, a CT pulmonary angiogram, or CTPA. So there you have it, a clear algorithm for both ACS and dyspnea, highlighting the critical first actions and, of course, the traps to avoid. The protocols are there to guide you, but at the end of the day, it's your clinical judgment that's going to make all the difference. The real question is, when that next patient comes through those doors, are you ready?